what is an unexpected frozen pelvis and what is an unexpected frozen pelvis, and then the strategies to go around it. So definition-wise, it's an adhesive condition that distorts the anatomy of the pelvis. An adhesive condition that distorts the anatomy of the pelvis. Something like this, when we see it in endometriosis, this would be a frozen pelvis, especially when you have an obliterated pouch of Douglas, the cul-de-sac, then that is a frozen pelvis. What are the possible causes of a frozen pelvis? Endometriosis is one of the causes and the major cause of a frozen pelvis. Oncologic situations can be another cause. Infections like PID, peritonitis can be another one. Radiation, following a radiation in the pelvis or in the abdomen, you may get a frozen or an adhesive pelvis. And then we have chronic infections like tuberculosis or something like that, which is also a cause for frozen pelvis. So this could be oncology. We have some infection. So these are all causes of frozen pelvis. What are the risks with a frozen pelvis? When this does happen, then you have the risk of conversion. I mean, it's not a complication, but it's a risk of conversion. You went in and you're not ready for it, and you'll say, okay, let's convert and do this open. I mean, yes, an option, but frankly, handling a frozen pelvis by an open route is not that easy either. Fistula formations risk is high. Incomplete surgery, you'll do an incomplete surgery. That's a risk, because when you do an incomplete surgery, you've not helped the patient relieve her of her symptoms, so you'll have other issues to follow. Hemorrhage, vascular, I mean, a frozen pelvis will have many neovascularizations that may have formed, and you'll get into vessels where you did not expect vessels. Injury to viscera like the bowel, the ureter, the bladder. Sepsis, so infective sequelae of such pelvises when operated on will be higher, and premature ovarian failure could be a resultant of this. Now, what do we mean by expected and unexpected? Expected means I worked up the patient, I knew this patient's pelvis is bad, and we know that nowadays from a good targeted ultrasound, which like the ones I do for endometriosis. So before I go in, I know this person's rectum is adherent, the lateral wall is pulled, the ovary is stuck to the uterus and the lateral pelvic wall, there is a nodule here. So that is called mapping, and you are knowing what to expect. So you go into a pelvis and there is an expected frozen pelvis, so you're not surprised. And then there is an unexpected. You went in thinking you're going to do a surgery, and they're like, oops, now what do I do? How do I do this? So that unexpected is not going to be free of consequences, because you would probably not have had enough consent for this patient. Did you prepare her that I'm going to likely do bowel here? Did you prepare her that she might actually lose a tube here? Did you prepare her that a bladder might be injured? If you didn't prepare her, are you okay with going on when you did not prepare the patient for it? Insufficient time allotted. You told her, I'll take 1 hour. I mean, this is straightforward. I think there is a small cyst, forgetting that the cyst is surrounded by all these adhesions. So you went in thinking you'll take 1 hour, and you go in and take 6 hours. Inadequate time allotted. You've messed the theaters up. You've not amply prepared the patient for it. She's not aware of the cost implication. It has challenges. Okay, no treatment or complete treatment. You go in, if you are not up to it and you're not able to move ahead and complete, you might do an incomplete surgery, or you might not do a surgery and come out. I would say it might be wiser sometimes not to, if you're not able to, if you don't have the confidence and the equipment to, and the skill to, don't. It's still safer than going and fiddling around, because you'll make it crazy difficult for the next surgeon. So you're better off saying, you know what, this was an unexpected frozen pelvis. I decided to do a quick diagnostic, take a few pictures and videos, and I will hand it over to the next team. That's fine. That's a sensible surgeon than someone who's going to fiddle around and do things and only make everything worse because of surgical adhesions now on top of what was already there. Complications. You will cause complications. You are not ready. And an unhappy patient. You did not tell her that you actually expected a frozen pelvis, so this could happen, that could happen, this could be done, that could be done. You didn't prepare. Unhappy patient. You don't want this, so avoid this. Avoid uncertainties or unexpected frozen pelvises. Assess carefully pre-op. Take a good history and examination. They tell you, our patients tell us what to expect. If they tell you dyschezia, do not sideline that history. Know that when she has intercourse that is penetrative, she gets deep dyspareunia. When she has passing stool, she gets dyschezia. Something down there is messing her bowel. Don't disregard that symptom. I have dysuria, I have hematuria sometimes when I have periods. There is something that is probably growing into the bladder. Don't disregard it. So start with that. Examine. You do an examination. The uterus is pretty much fixed. It's not mobile. No, that is not a good pelvis. Why do you have to go in to look at it only to say, yeah, it's not a good pelvis and come back? We didn't need that. So bimanual examination will tell you that. Imaging, TVS, MRI, we've discussed this, obviously. With a good targeted, not a routine TVS, a good targeted TVS that is looking for dynamic changes. Changes like site-specific tenderness, changes like a sliding sign, changes. That is what's going to tell us this difference of a frozen pelvis. So if it is already there, look what we found. Fine, we were to do this, but this is what we found when we got in. So the next question is what next? So we are today to unravel what we should be doing in such a case. Okay? When you come across this, all right, what should we be doing? First of all, let it not come as a surprise. We've discussed that part. If it did come up and you are ready for it, what should be done is what we are discussing. So it is like a jumbled jigsaw puzzle, which has been mixed up because there is no anatomy now, and you are told, put everything back together. I want the uterus where it's supposed to be and the ovary where it's supposed to be and the bowel away from it. It shouldn't be stuck to each other. So you're trying to unjumble the jigsaw puzzle and put it back together. And we definitely now know without a doubt the way to do that best is laparoscopic. Do not think you can unjumble this with this route. It's going to be crazy. All right? One, it will be difficult, but two, you're going to leave lots of other sequelae in this patient. So the best approach would be to approach this by the laparoscopic route. So when we now have this is what we mean. It's like this, and you're told, make this car brand new. Okay? So our job is to make the car back to brand new, this one. Okay? So how do we get the car to this? Number one, there is something called point of no return. So what is point of no return? We're going to discuss this in step by step. So number one, you entry carefully. So a frozen pelvis could have a frozen abdomen. So be careful when entering. Know where to enter. Know those additional entry points. Go into places like the subcortical Palmer's point or the Jane's point or supraumbilical, but you go in carefully. So you'll have to decide how to go in carefully. Then do a quick inspection. So you've done an inspection and you found a pelvis that is frozen. You have two options. You either stop or you proceed and take off. Okay? So you stop or you proceed and take off. But if you take off, for pilots who are ready to take off, if you take off, can you imagine a pilot, you sit in a plane and you say, you know what, guys, welcome to Air so-and-so. We are flying our flight to Kinshasa, for example. The first officer is going to be taking you through He's taken off, but he's never landed this flight before. I'm coming and joining you guys. Let's see. Do you think you'll sit in that flight? All right? You'll run off. You get it? So once you're ready to take, there is something called, with the willingness to take off, comes the obligation to land that plane. All right? You need to know how to land the plane. If you take off, what do you need? You need a strategy. You need a team. Do you have a strategy? How will I approach this? Do I have a team that will tell me or guide me through? What do I mean by team? I come across bowel. Do I have a colorectal around me? I mean, you may also need to know it, but do I have somebody as a backup? If I have ureter injured, do I have a urologist? If I have, you get my point, comes the strategy and the team. The knowledge is important. You need to know what to do, the knowledge. The skill is very important. The experience is necessary. And a surgical intuition. What do I think will happen if I cut this? Oops, vessel. You should have known that my intuition tells me this is a vessel. Okay? I don't want to cut it. I want to circumnavigate it. So that is called surgical intuition. Intuition is not taught. Intuition will develop internally. Got it? So you should have an intuition. What about knowledge? Now let's get down to knowledge. What knowledge do I need to unravel a frozen pelvis? I need anatomy. I need knowledge of energy. I need knowledge of exposure. I need to expose this area. If everything is stuck there and the ovaries are falling down and this, I may need to expose the pelvis by lifting off. I need principles of dissection knowledge. I need knowledge of the disease. Am I dealing with the cancer here? So how does it work? How does it spread? This is endometriosis. What is about endometriosis? I need to know this. I need to know how I'm supposed to do hemostasis. I can do it by buzzing. I can take a stitch. I can put a clip. I can put a Surgicel. I can put a Surgisno. Do you have options? You get it? Do I know how to handle bleeding if it happens? I can do a vascular repair. If you don't know A to Z of this, don't proceed. Because you don't know which of this knowledge and experience you'll need. Got it? You might need buzzing, and if it's you saw that video yesterday, if it's a vena cava that you injured, do you think you can go and buzz the vena cava and expect it to stop bleeding? You can't. So you need now therefore to change strategy there. So you don't take vessels that are big and think hemostasis will be achieved by the buzzing. It won't work everywhere. So you need that knowledge. You need to have available resources. You need to have transversal competency. What does that mean? If you are a surgeon who is to tackle difficult pelvises or abdomens, what is transversal competence? I should be competent in more than one skill. I should be able to dissect and open a bladder and repair a bladder. I should be able to do a resection in the rectum and repair if necessary. I should know how to do a circular stapler. I should know how to do ureterolysis. So that, I don't need to call, I should know how to do an appendix surgery. So that is called transversal competence. You're competent in more than one field. So if I'm dealing with the pelvis, and the pelvis has the nerve and the vessel and the ureter and the bladder and the rectum, I should know knowledge and skill around all these structures. Okay? Additional multidisciplinary team, we said, management of emergency situations. So if something does happen as an emergency, how do you handle it? If there is a major bleed, how do I handle it? If there is an injury to the bladder inadvertently, how do I handle it? So you should be able to handle that. Check tests. You should know, after I do this repair, how do I do my safety check? If I don't know how to do a safety check, you don't proceed, because you've done a repair. Are you sure it's 100% hold? You saw what they did when Prof showed us, or was it you, when we showed us a video of a repair of the bladder, and then they filled up the bladder to see if it was watertight. Remember? So you're checking. That is ways you check. Those are safety tests. You do a cystoscopy to see my both ureters are pumping in urine. You've not ligated a ureter by mistake. Safety test. Okay? And you should know knowledge of post-op management. Now imagine how much you need to know before you handle a frozen pelvis. Okay? This is only knowledge. Then the next thing that happens, so when you're dealing with nodules in the in the nerves there, near the uterosacral. There are the major vessels down there. You can't attach this, you can't attack this area without this much knowledge. So this is transversal competencies that we as advanced surgeons need to know. For ureter, we need to know double J placement. We need to know reanastomosis if need be. Obviously, have your team and the team will come and do this, but you need to know it. Reimplantation and ureterolysis, definitely. For bladder, you need cystoscopy and repair principles. For bowel, you need to know suturing. You need to know discoid, whether it's Hansen or circular staplers. You need to know shaving techniques. You need to know segmental resection and anastomosis. And you need to know about a protective ileostomy or colostomy. Okay? So you don't proceed with this type of pelvis without this information. And for vessels, you need to know clamping and repair policies. When to call and work as a team, we are talking of the multidisciplinary team approach. So for the frozen pelvis, we need to know MDT. So what are the strategies now for this obliterated pouch of Douglas? Number one, optimize visualization first. Surgery, laparoscopy, you can't operate if you can't see. So number one, it's a frozen pelvis. You can't operate if you can't see. So first, create view. Next step, identify and restore your anatomy. So you have now created view because the bowel was falling in, you've moved it away. The tubes were falling in, you've moved them a little away. But now the anatomy is all messed up. So step two, restore this anatomy. Okay? Step three, develop the spaces. You heard this in that talk on endometriosis hysterectomy. I'm just laying it down from frozen pelvis. Step four, after that, go posterior compartment and clear the disease in the posterior compartment if need be, because that's where most of the disease is in the frozen pelvis. It's the pouch of Douglas obliteration. Then do some safety tests at the end of it to make sure whatever you did is still not injured any visceral organ. And do adhesion prevention measures and have good knowledge on post-op. So how do you optimize visualization? Number one, you need a good OR setup. Okay? In the OR setup, you need, for visualization only, you need the right team to guide you. So a good camera person, a good assistant to hold and expose for you. Right equipment. You need good quality equipment to see and handle a frozen pelvis. Right port placement. I told you, if you put your ports in a wrong place, you have to think. When you put in the primary one now, you have to think, where do I need my next ports? There is no standard ports. When you're dealing with such a messy abdomen, you might have to modify slightly. Where do I put them so that I can work well and I can get good view? Correct patient positioning. Yes, I will need a Trendelenburg position to see this area, or I will not need. You need that information. Imaging should be good, and situational awareness. Be aware of what is around when you're doing it. So, Trendelenburg position, how, when, how much. Ideally, 15 degrees should be good, but sometimes we go up to 30 degrees or steep Trendelenburg. Keeping in mind this has more risk of injury and slippage, so you need support, a strap, you need shoulder braces. Again, shoulder braces should not be put too lateral or too medial. You will get injury on the brachial plexus or the neck here. So you have to make sure that the support is partly on the shoulder, and that will prevent the patient from slipping. Having anti-slip mats. These mats, there are some available that are called anti-slip mats. Yes?
That's very important, the anti-slip mat. For example, in Belgium, the stirrups are forbidden.
Yes, because it causes injury. Yeah. The shoulder braces are even forbidden, you heard that. So anti-slip mats are better. Then the next, in exposure, we would now mobilize the sigmoid or the bowel from its physiological adhesions. So the adhesions we saw today morning, if there was an obliterated pouch today, that's the route I would be using. It's the entry to the retroperitoneum. You enter from the normal, go towards the abnormal, and you start from above the pelvis and trickle your way down in. So the most common area we would start off with is the sigmoid. Then we might need bowel suspension if there's a lot of bowel pulling in. So you suspend bowel by taking a suture or a T-lift and pulling the mesentery on the upper side of the abdomen on the left side. I told you, remember I mentioned in the morning, large bowel is tractioned on the left, small bowel, don't do this. Small bowel is tractioned on the right, okay? So you then expose. Once you have exposed that part, the next exposure could be done with manipulators. So you may need a manipulator. We needed a manipulator to guide us with the uterine anteversion and retroversion. This was a very simple manipulator. It was just a tenaculum, a valsalum with a sound on top of it. So it's a specialized, simple gadget that you just put in the sound, and then you hold the valsalum and you lift it up. So it is something very simple, but you will need some sort of retractors or manipulators for bowel, uterus, etc., etc. Rectal probe. You may need different types of manipulators to give you a good view. The next level, you now are identifying and restoring anatomy, so you need to know the anatomy to restore it. If you don't know the anatomy, how will you restore it? So first, learn the anatomy. We have another talk on retroperitoneal anatomy that we'll be taking, I think, in the next 1 or 2 days. Then you should know what is predictive anatomy. Predictive anatomy means you don't open and see it and it bleeds and oops, okay, that was the external iliac. You should know, predictive. I'll open this and I'll see the external iliac. I'll move this side and I'll expose this and I'll see the ureter. I'll move this side and go under it and I'll see the internal iliac anterior trunk. You getting my point? That's called predictive. I will expose here and the nerve should be here. So that is predictive anatomy. So your knowledge should now be so good that you can predict what structure will now come up. Okay? Next, reestablish your landmark. So in a frozen pelvis, it's difficult, there is no anatomy, but you have your landmarks. At this point, this is the external iliac. The ureter crosses the right side over the external iliac. So if you see the external iliac, you don't have to go too high or too low to look for the ureter crossing. It will be crossing on the external iliac. So you expose there and you will soon see the ureter. You getting my point? So know your landmarks. If you know your landmarks, you know what to look for at which place. Otherwise, you'll be digging everywhere looking for something that is moving like a ureter. All right? And that could land us into unnecessary problems because you sometimes start exposing vessels, which can be dangerous. How does this help? It reduces uncertainty. It makes you take a better decision. It gives you better management of any emergency should it arise, and it gives you better outcomes. So in strategy, we have two major ways of looking at it. We have general strategy and specific strategy. So these are the strategies for principles of restoring anatomy. Number one, go from known to unknown or normal to abnormal. Take easy parts first. Don't attack the difficult parts. Start easy, start easy. Make more difficult easy when you do that. So the difficult parts become easy when you start from easy to difficult. Then expose. Give ovaries up, fix them up, or tubes away out of the view, bowel fixed up. Now you have a good exposure, proceed. Find the gateways to the peritoneum and go in there. Avoid direct confrontation with pathology. Use divergent forces, traction, counter-traction, traction, counter-traction. That's how it will help you. Otherwise, don't go direct and go millimeter by millimeter. Don't be in a hurry. Don't take a big bite and cut it. Take small bites, small bites, small bites. Oops, something is coming up. I don't want to injure that. It looks like a vessel. So you see, it gives you time. It gives you, otherwise you'll cut it only to realize it's bleeding. Then you say, okay, bipolar. But really, it wasn't necessary. Go millimeter by millimeter if it's a frozen pelvis. Don't irrigate. My policy, I know people may have different opinions, but most people who deal with complex surgeries and pelvises do not irrigate. I will suction out blood, but I'll not irrigate. You saw even in this case, I did not irrigate until the end. Now the reason is, when you are looking at, I think it was you were saying, you follow the bubbles to give you direction. You've mentioned it, Prof has mentioned it, you've heard we are saying similar languages. If you put in saline there, to wash it out, those planes will be gone. Now you'll not be seeing those bubbles. And when you don't see the bubbles, you don't know where to dissect. Okay? So don't irrigate. Avoid staining if you can. So you get small bleeders, just buzz them as you go. So because blood will make the field dirty, and when the field is dirty, your planes are not seen. Short bursts of energy. Don't cook till it becomes black. Same points. There's nothing new. Short bursts, then continue. Okay? Use a manipulator to suspend. Allow space. Follow planes. Do plane surgery. Planar surgery. Do follow planes. Don't go into wrong planes. You'll have adhesions and you'll start bleeding. 2 hand movements with an assistant hand as well. What does that mean? My students, you see how I get angry with them. Even if you're holding a camera, I tell them, listen, you're not a one-handed surgeon. Don't do this. Don't think you're doing sword fighting here. We are not doing sword fighting. We are doing surgery. When you're doing surgery, I need your assistance as much as you need mine to work. We pull each other, we stretch, we do traction, counter traction, I cut. You get my point. Camera person, he's holding, he's supposed to show me left, right. Why are you driving with one hand? I'm boss. All right? Don't avoid one hand driving, avoid one hand surgery. Learn and practice to use 2 hands. That's the only way to operate well. Okay? Identify and dissect ureters if necessary, but if you don't have to, always keep them under vision. I did not need to do ureterolysis today. I did not need to expose it. I did not see the need to. But remember, I was still showing you the ureters all the way down. Even when I removed that small nodule that was down there, I showed you this is medial to the uterosacral. The ureter is lateral to it. I don't need to worry. So keep it under view at all points. And dissect paralesion first, then go towards the lesion. So start lateral, go medial. If there's a bladder nodule, even in previous cesarean section scars, if there's adherent in the middle, don't attack the middle. Start lateral, then you will free the bladder that way, and then cut here and release the bladder. Okay? So that's a rule even for those who are doing cesarean sections. Don't attack the bladder that is stuck there directly if you're not sure. You'll open the bladder. Okay? So, dissect avascular pelvic spaces. These are potential spaces. They don't have vessels and nerves, so it allows safe surgery. And use these 2 dictums. Fat belongs to bladder and fat belongs to the rectum, so the bowel. So, if you open a space and you see fat, it's anterior, go under the fat, so push the fat with the bladder. Don't go into the fat. You will bleed and you might open the bladder. If you open behind the uterus and you open and you see a space with fat, please understand the vaginal wall that is in front here and the uterus that is in front here and the cervix that is in front here does not have fat. Does it have fat? So why should you get into the fat now? So you know what you do? Dissect above the fat, where you reach now there is no more fat. Now push there and everything will go down like a curtain. You've understood? So that's the principle. Fat belongs to bladder, fat belongs to rectum. These are the spaces. We'll talk about this in the anatomy. Now we go to specific strategies. Specific strategies, those are general strategies. Specific strategies to deal with the frozen pelvis. For the ureter, visualize it all times. For the bladder, we'll decide, but if you have any risk, do a cystoscopy. For the bowel, what are the specific strategies? For the uterosacral and vagina, what are they? For ovaries, how do I handle it so that I minimize ovarian damage? That is your specific strategy, okay? So, once you've done the specific strategies, because it depends now on which organ you're dealing with and what pathology you're dealing with, now you go into safety tests. So, you should know and you should be able to do this confidently. For the rectum, air insufflation test and methylene blue test. All right? And nowadays they even have ICG dye test to check vascularization. If you have done a resection and anastomosis, you may have to do this. So these 3 tests, you should know how to do them. You would put saline in the pouch of Douglas, you will put a probe in, and then you will block the bowel at the top with just an instrument and push in around 60 to 100 cc of air, and it's like a puncture test, you know, the tire puncture. So if there is a leak, what will happen when you have put saline in the pouch of Douglas and you push this, bubble. When you see a bubble, you know, okay, there's a puncture in this tube. You'll have to repair that tube. If you don't repair that tube and found that puncture, my friend, that tube is going to leak into the abdominal cavity. Understood? Sepsis. So do this test. Is it enough to do that only? Sometimes maybe not. You do a methylene blue test. You may not have caused a puncture, but you have shaved off everything and you have left mucosa. Only mucosa. So what will happen? After a while, that mucosa might break away. Okay? So when you do methylene blue, you will not see bubbles. You have not seen bubbles, but you will, because the mucosa was intact. But then you will see a blue spot there on the mucosa, because mucosa will stain with methylene blue. If you see a blue on the bowel, take overrunning sutures, because if you don't bury that in, that might open up. You've understood? So they are not either or. They are, if you have to do the safety test, if you have to, I'm not saying you have to do it in every patient, but if you have to do it, it's not either or, it is and. Okay? And this is the or. ICG is for the vascularization of the bowel repair, it's or. Then bladder, you should be able to do a cystoscopy. We've just done a quick cystoscopy, one for demonstration, but two because the diagnosis I was given was endometriosis. Sometimes it's good to go in and quickly see there's nothing in the bladder, the rectum, the trigone is clear. So that is, you should be able to do it either before or after a repair. Then you should be able to do retrograde filling with saline. So the way you were seeing yesterday after the repair, they fill it up. You can do with saline or with methylene blue saline, so that you see if there is any blue leaking out. All right, if there is, take sutures there, because that means there is still a leak out. And then ureter, you should be able to see the ureteric jets on cystoscopy, and you can do indigo carmine dye. If you inject indigo carmine dye, in a few minutes, in less than a minute or so, you will see the colored urine coming out. So you'll actually see colored urine. If you're not sure in the abdomen that you've cut a ureter and you know you're cleaning and there's more filling up of the pelvis, cleaning and more filling up because the urine will be leaking into it, for example, then if you've done indigo carmine, you'll actually start seeing colored urine coming out. You get what I'm saying? So it'll tell you, oh, there's something wrong here. You've understood? So you transected the ureter. You should know how to then look for that ureter and repair it. And what is the role of peristaltic movement? No. You know, some people say, yeah, but you see the ureter is moving down. You could have chopped it here. It will still be peristalsing here, guys. And it will be leaking urine here. You've understood? So how effective is this in safety? Maybe not. Because it will still be peristalsing even though you've cut it. Okay? So this is what we mean by this is a moment of truth. This is what we mean by a test. So you fill this with saline. Now you block here with an instrument and you push in air, and you will see the air coming in just now. The rectum will blow up like this. See that? And then you check, yes, yippee, no puncture. All right? So you've done a crazy pelvic clearance like this. You need to be sure of this, guys. If you're not sure of this, don't leave that abdomen unsure. Now you go home and sleep a comfortable night. They'll not call you. But otherwise, yeah, you're going to always going to have a problem. So you've done the procedure, you've landed the plane safely, then you can leave this plane. Finally, you can leave the flight safely. Finally, adhesion prevention. To me, I always mention the best adhesion prevention technique is your surgical technique. If you do a poor surgery and then it ends up in adhesions, don't blame the patient. And don't say, some people, they are very adhesiogenic. But you are the one who did surgery in the wrong planes, right? And then you're saying adhesiogenic patient. So please follow planes, please use the right principles. And then yes, you have other options. You could have hyaluronic acid for the uterus distension, or the gel that is put, or the powder. So there are different things. Cellulose-based intercede. So
hyaluronic acid here?
We get one option. There's a gel. Yeah. Yes, we have a gel. And then we call it Medicurtin gel here. And then follow-up. You should know about follow-up. It should be uneventful. There should be a daily tendency to become better. If you see it up and down, then please know something is wrong. Don't blame the patient and say, you're just too complaining type. you keep quiet. I mean, hello, if she's telling you she's not feeling well, take it seriously. Do tests and examination, have a clinical acumen, check her CRPs in endometriosis. Advanced cases, I do check CRPs on follow-up, check a hemogram, and you just check the WBCs are not rising or whatever. Early mobilization, ERAS protocol, good antibiotic cover if it's very complex, and an early second look. If you're doubtful, you're safer of saying, you know what, let's just go back in and please check everything is fine. Don't wait till she becomes septic and then in septic shock, and now you're going to be battling a very big battle in your life. Trust me, you don't want to get there. Thank you very much.